Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a sports and shoulder surgeon at Wake Forest. Brian, how are you?
Hey, doing great, Peter. Thanks to our guests for joining.
Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, so today I'm very excited. We have an episode where we're going to talk about a hot topic in shoulder surgery, which is the use of guidance in shoulder arthroplasty. So since the development of 3D CT blade planning software by Pascal Boileau and others, many surgeons are now planning all of their arthroplasties. And while I think most would agree that this is helpful, the next step is to take that plan and replicate it in the operating room. And there's a couple of different methods you can do that are currently being used. So to discuss, we've invited a couple of experts from around the world. So first, from the Mayo Clinic in Florida, we have Dr. Bradley Schoch. Brad, welcome to the podcast.
Thanks for having me, guys. Happy to be here.
And then from SUNY Buffalo, we have Dr. Thomas Duquin. Tom, welcome to the podcast.
Thanks, Peter. It's a great pleasure to be here and excited for the conversation.
And then finally, from Macquarie University, all the way in Australia, we have Dr. Sumit Raniga. Sumit, welcome to the podcast.
Thank you very much, Peter. Thank you very much for giving me this opportunity to discuss this very interesting topic.
Okay, so I want to start with planning. So let's start with you, Dr. Raniga. Are you planning every case, or are there times when you're comfortable to do an arthroplasty with plain radiographs alone?
Peter, I plan every single case. So I do 3D planning for every single case I do. There'll be the odd case where, because the planning software doesn't allow accommodation of planning because of metalware or some other issues, where I won't. But even then, I manage to get around some aspects of that and plan every case I do.
What about you, Brad? Are you a plan every case guy, or are there some cases where you'll say radiographs alone are sufficient?
So I as well will plan every single case based on a 3D CT in some form of commercial software. In those rare cases that have metal artifact where the reconstruction fails, then I will plan my version inclination and augments that I would need based on those corrections using a reformatted CT. As you've shown, to get more accurate version inclination, you need to put it into the plane of the scapula along Friedman's line. So that's kind of my backup that I will do if the 3D planning software fails. But every single case, I go into the operating room with a plan ready to go.
Tom, same for you? Every case is planned?
Yeah, pretty much the same here. Definitely CT scans on everybody, using 3D planning software whenever available in my cases. So I think it just really gives you the opportunity to better understand the anatomy and see what you're getting yourself into prior to even getting in the OR. So the old "be prepared" motto makes sense in this case. So for me, I'm a plan all the time kind of guy.
Yeah, Sumit, it makes sense. You're in a nationalized healthcare system, or at least I think you are. And obtaining imaging is probably a little bit different here than here in the States. I have the occasional patients that come in, X-ray, MRI. Maybe there's some financial issues at play. I'm just curious, Tom and Brad, are you taking those people and sending them back for an additional CT scan? Is there a discussion there? Maybe how are you navigating that? Or let's take it a next step further. Insurance does not authorize that. There are still some plans that fight back on this advanced imaging. Maybe Tom, can we start with you?
Yeah, sure. No, that it never was a problem years ago. I feel like we're starting to run into that a little bit here in Buffalo. I think we've been maybe a little bit lucky with the insurance companies that are in our area. For the most part, we haven't run into an issue other than occasionally me having to get on the phone and doing a peer-to-peer or something along those lines, but that has been pretty rare. As far as as you mentioned, with patients who have an MRI or existing imaging when they arise, that's not CT scan, that's compatible with the planning software, I still will try to get the CT scan. Most people are understanding of this, and when you discuss it with them, the ability of looking at it in 3 dimensions and actually having the ability to place the implants for better understanding in the virtual world of what you're going to encounter. Most of them are more than willing to go through the CT scan to obtain the benefit of that. But if someone really puts up a fight, I'm not going to argue with them. If they have an MRI, I think that's sufficient for me. Using reformatting to be able to kind of understand what's going on in those cases.
And Brad, do you massage the messaging any different down in Florida?
Yeah, I mean, at my previous practice, that was more common. It's less common here with insurance issues not being able to get a second imaging study. Over time, as I've practiced longer, you kind of learn tricks too on how to work the system of, making sure that you document that there's bone loss. I think if there's bone loss, it's hard to let an MRI alone constitute your plan. You can do it certainly, but it's just a little less forgiving, more likely to have errors. So I think CT is better for that. So, and the other thing is to remind those that are in the United States here listening, on Doximity, you have access to Chat GPT, and it's great when you have to send in letters for medical necessity. You can just type in and tell it to write a letter to say that a CT is needed for a shoulder arthroplasty, and it will spit it right out for you. And I've actually done that and used it, and it's very efficient. Just a plug for that.
Yeah, so I mean, I think that sets the stage. I agree with you all. I think this establishes almost universal consensus, at least among this group, that CT is definitely the gold standard for planning. As we continue to plan, and let's look at an anatomic total shoulder replacement. Sumit, what are your targets for this? I mean, we can really build in what we want, either using allograft, using host bone, or with metal. And so I'm curious what you're looking to establish when you execute your anatomic total shoulder.
Yeah, so first of all, with regards to anatomics, the first thing for me, I'm sure it's the same for all of you, is to understand the exact nature of the pathology. So for me, if you have a significant degree of subluxation, posterior erosion, and you're getting to a B3 stage, I probably won't do an anatomic total shoulder arthroplasty unless I'm willing to do a big, large wedge correction, which I'm not at this point in time, because I'm not sure that's the right way to go, and the evidence not completely clear on that. But when it comes to a routine anatomic total shoulder arthroplasty, which is concentric wear, not significant erosion posteriorly, and it's not subluxed, I just use Professor Walsh's golden rules, and I try and plan my operation through those principles. I have a very good planning software that is by an Australian company called Precision AI, which Innovus has recently bought. It incorporates Ionotti circle as a precision sphere, so it allows you to make sure you don't overstuff. And it also incorporates critical shoulder angle, which has been shown if you leave the critical shoulder angle very high postoperatively compared to preoperatively, there's a increased incidence in glenoid failure. So I try and incorporate all the latest evidence that we've got, and luckily for me, the software allows me to do all of that and try and balance the shoulder to the best of my ability and get good back surface contact. The other thing I must say is that I don't use a cemented component. So I basically use a component by Matthews, which is a Swiss company that is a vitamin-infused polyethylene isoelastic with a blasted back component that doesn't require cement. And I use a ceramic head as well, and it's a short stem. So that's the components I use, and that's the planning software I use. But I'm very careful about who I offer anatomics to and make sure that the cuff is intact through MRI as well and in clinical examination. And that's the way I plan it.
And now, so Brad, talk to me a little bit about some of the topics that Sumit has touched on, and then also delve in a little bit about what is your acceptable endpoint for either inclination and inversion. I think for everybody, it's a little bit different. So maybe if you could encompass that, as well as your backside contact for your glenoid and your anatomic desired tear.
Yeah. So my rules that I will follow is I try to keep it 10 degrees of less of retroversion on the final face of the glenoid component. I will accept 2, maybe 3 degrees of superior tilt on my anatomics And that's more to save subchondral bone. I really don't want to see any cancellous bone when I ream. I want it to have nice, good support. And that's based on an article by Mark Frankel's group where they showed increased rates of glenoid loosening if you have larger, more volumetric subchondral cyst formation within the glenoid, just like having a foundation on either really good concrete or crumbling concrete. So I want that to be good, and I don't want to get into anything that's weaker. I use the 80% subluxation rule from Walsh for as far as how much posterior subluxation that I will take. And then other things I think about, I will look at rotator cuff muscle, fatty atrophy. I personally get an MRI on everybody that I can if I'm considering an anatomic to look at the rotator cuff, because there are absolutely cases where you can examine it intraoperatively where it looks just fine superiorly, what you can see inferiorly, but there's a high-grade intersubstance tear with intact bursal and articular sided fibers that you would never see if you didn't get an MRI. So it's probably not the most cost-conscious thing, but if I'm going to put an anatomic in somebody, it already gives me angst to begin with if the subscap will heal. So I want to stack that person's deck to make sure that they have the best chance to have a really good shoulder.
Yeah, you're certainly assembling all the appropriate information there. I guess maybe my question back to you would be, do you feel that the MRI is overly sensitive to rotator cuff pathology? I think very often doesn't quite match up with reality once you obtain the exposure.
Yeah, I mean, certainly on my fellowship group chat, we have these things where an MRI cut will come out and say good enough for an anatomic, and we'll disagree. So I don't think that we as shoulder surgeons know that yet. And it's probably because we don't know what's going to be a symptomatic rotator cuff tear versus a gray-haired rotator cuff tear that's well compensated, that will continue to function very well with an anatomic prosthesis in place. So until we have that figured out, I can't tell you what's clinically significant and what's not clinically significant purely based on the MRI. Right now, because of how well a reverse does, it's hard for me to justify gambling on an anatomic if the rotator cuff does not look really good for me, unless my patient really wants to return to swimming, which I see a lot here in Florida, or higher level tennis where they need, near 180 forward elevation. Otherwise, I really don't want to gamble in that situation for my patients.
So the mistake you made is you live in a state that's surrounded by water. And if you live in a landlocked state, I don't have this problem with swimmers. But I want to ask you, when you talk about the reverse, we've talked about anatomic targets. I want to jump through reverse targets real quick. I want to focus on the glenoid because I think that's where most of our instrumentation really allows us to, guide at this moment. Just real quick from each of you, inclination version targets for your reverse. Brad, go.
Oh, Pete, that is a loaded question, because you could ask me, and you could ask me today or in a month from now, and based on the Exact Tech article on this, surgeons don't plan consistently unless you're PH Florin from France. He plans it the same way every single time. Otherwise, we tend to have some variability day to day of ourselves. I, again, try to keep it within 10 degrees of neutral as far as version goes. I won't do more than 10 degrees of retroversion on the face of my component. That's without the augment correction. And I won't do any superior tilt. I am perfectly fine at neutral. If a few degrees of inferior tilt requires me to remove less subchondral bone, I will do that. So 10 degrees of version, neutral or inferior tilt are the targets that I'm looking for, along with a millimeter or two of inferior overhang with the prosthesis that I use.
Tom, any differences there?
No, I mean, pretty similar for me compared to what Brad said. So I'm usually shooting for neutral version whenever I can. It's pretty rare that I'll deviate from that with the implants we have, like augmented base plates now. It takes a pretty substantial, bone deficiency problem or some other unusual thing like a dysplastic glenoid for me have to deviate from neutral scapular version. And I think that gives you the best opportunity for, screw fixation, as well as, once you start changing version on that stuff, you can really end up chasing your tail. and running into, impingement issues and internal external rotation, and what are you going to do on the humeral side now? So for me, I'm trying to keep it simple, keep it at 0 whenever I can, maybe plus or minus a few degrees. And then inclination wise, it's between 5 degrees inferior tilt and neutral inclination, based on the patient's anatomy. So thankfully, with the implants we have now, it's pretty easy to execute that, without removing too much bone.
I want to ask you a question. I've always kind of wondered this with people with philosophies of shooting kind of for 0-0 or close to it. How do you kind of weigh, would you rather take more bone to get to 0-0 or preserve bone, correct what you can with the augments to not quite 0-0 and preserve the subchondral bone? I know with the prosthesis you use, the central screw may also dictate some of where that lands, may dictate what you choose to do. But I kind of want to hear how you think about taking bone versus accepting off of 0-0.
Yeah, so I pretty much stick to 0-0. With the different sized augments that we have, we're able to achieve that in most cases. I think the bigger thing is, jumping between a different sized augment. So am I jumping up to a larger augment, which may actually volumetrically remove less bone, or using a smaller augment that might, shift the center of rotation. So, in most cases for me, the difference comes down to whether it's a millimeter or more of lateralization savings. So between augment sizes, but it's pretty rare, like I said, with has to be a pretty deformed glenoid. We have a 30-degree, half wedge, as our largest augment. And I don't even need to use that most times to get back to 0, with a 5 degrees inferior tilt. So, nice part is you can position that augment in any orientation. So with it being circular, it does allow for addressing, all these off-axis deficiencies, pretty easily with the system. So, and planning's nice for understanding that.
What about you, Sumit?
Just to add to that, thanks, Peter. I'm very similar in terms of numbers. I use a system where I use bio-RSA nearly every time. The bio-RSA graft is also planned for intraoperatively, and we have a system of actually creating the angled graft as per the correction required intraoperatively. So we have a harvesting system and then also a shaping system, and that's done exactly as per my preoperative plan. My numbers are exactly the same, neutral to maximum 5 degrees of inferior tilt, and I go between 0 to 10 degrees. But the reason, the way I decide what I end up with is where I'm going to get the best fixation on contact, because that's quite important in reverse as well. And that's why I don't veer away too much from that. In terms of humeral torsion, which we haven't spoken about, I do 20 degrees of torsion generally, but there will be the odd patient that's really way off. And I think Philip Moroda's work is sort of making me think a little bit about that a bit more with some of my patients with regards to their scapular position. And that's something that we're working on in our lab as well. And I'm getting the feeling that Philip's idea of retrotorsion having an effect with regards to scapulothoracic motion and stiffness and positioning is probably relevant. And so I'm thinking about it a bit more, but obviously we need more evidence.
So I think that's a great point. One of the things I think is so interesting about everything you guys said, and we've set this up purposely this way, is everyone's planning and everyone's got strong opinions about where they want their implants. I mean, I think we've heard from everyone that people think that implant position really matters and that we're trying to get it degrees perfect. So that's part of the reason I wanted to do this podcast, is I want to go from here where I think we're all in pretty good agreement that we really care where the implants go and what their alignment is, and we're planning to meticulously achieve that. And I think the question now becomes, you go to the operating room, how do you execute that plan? Does that mean you have the instrumentation you're talking about with the bio-RSA? And again, there's a couple of different methods of doing this. So I want to go, I know we've purposely selected you guys because I know you guys are all doing this slightly differently, and I want everyone to talk about, what is the form of guidance you're using in the operating room? Why do you like it? What are the good parts? What are the bad parts? Because I think that we're at a little bit of a crossroads in our field, and it's an interesting time. So maybe we could start, Sumit, you got us into a little bit of the instrumentation used for your graft. Tell us what is the method you're using right now in the operating room to replicate the plan to get the targets you just discussed?
Peter, just to go back on that first point you raised, this is the same point that I also feel in the back of my mind is that, it's great to be really, really accurate, but are we hitting the target? And do we really know what the target is? And I think that's where, as you and I have discussed before, basic science is really understanding clinical sciences to understand what the targets are. Is it really universal? Is it going to be applicable? Is really important. And that's something we're working towards. But based on the understanding each of us have, we do have targets, and it'll be nice to be able to execute accurately. And for me, at the moment, pretty much every single case I'm using patient-specific instrumentation, so PSI guides. I have a bi-RSA preparation with part of my shoulder arthroplasty system that also allows me to prepare the graft perfectly as per my preoperative plan. In fact, the PSI print also has the bi-RSA graft to check with that. So my intraoperative execution is all done PSI. Now, the odd time I will use navigation because the system I use also has navigation. And therefore, I will only use that when I have a very, very difficult bone loss situation where I really need to have good screw fixation and exactly where I need it to be because there's very, very small targets for where the screws can go. And that's where I use navigation as well. And so I use a hybrid technique sometimes. I actually have a PSI guide for my humeral side, Peter, and my glenoid side, not just the glenoid side. So my humeral cut is done PSI guided, bi-RSA is done PSI guided, and then I execute my glenoid plan PSI guided, but I will bring in navigation when I feel there's so much bone loss that I want to get the screws in exactly the right position with the good length. And so I think that's what I try and do at this point in time.
Incredibly thoughtful response, and I love the way you frame that. You bring in this concept of precision, right? Precision and accuracy, and then also, where the best host bone is. I think as we talk about PSI guides, it's important to articulate, is this a reusable one that can be customized and reused for repeated cases, or is it a 3D printed guide as has been described for several cases? Maybe Tom, if I could go over to you next and you can walk us through what you're routinely using as your form of guidance.
Yeah, so I've been using robotics. Excuse me. At this point, sorry. Sorry. Yikes, frog my throat. So yeah, I've been using the robotics platform at this point, using the ROSA shoulder system for the majority of my cases that I feel any need for PSI or anything else. So I've kind of abandoned PSI at this point. The robot, obviously is a little bit more time friendly. I can get my CT scan and plan it and execute the case, that day or the next day, as opposed to having to wait for a 3D printed guide, as you mentioned. Benefit also is we have, the humeral side as an opportunity here in the U.S. Unfortunately, I don't think there's any humeral PSI available outside of the Matthias, but that's not. I'm not sure if they can get that here. So with the robot, we're able to do humeral side, which I know we didn't discuss much in our targets, but realistically, especially for an anatomic, I think restoring the center of rotation on an anatomic is much more difficult, maybe even than getting the glenoid right in an anatomic. So having the opportunity to plan that using software and then being able to execute that plan, making your cut where you want it, and then validating that cut to know that it is where you planned it, I think is critical for that. As has been mentioned, we have all these targets in our mind, and then we go and execute, even if it's with PSI. Most people are not getting three-dimensional CT scans after their cases to confirm that those implants are in fact, where they left them. We have good studies in cadavers and other models showing that they work, but we don't have a great study day to day probably replicating that. So, the nice part about using a navigation or a robotic system is you can actually validate the position of your implant when you leave the OR, so you know exactly where that implant was left. And I think that's the data that's going to be critical as we move forward with, looking at big data and trying to analyze where the optimal implant position is going to be, for individual patients, but also, in general. So obviously we're just at the starting of this. There's still a big learning curve, associated with robotics, but so far it's been a great tool for being able to accurately execute that plan, both on the glenoid and the humeral side for me.
Brad, close us out. What are you using routinely for your guidance intraoperatively?
So I've been navigating nearly all of my shoulders since 2017 when the first navigation system came out in the United States with the GPS unit. When I talk about this, one of my favorite things to say is, 95% of orthopedic surgeons think they're in the top 5%. So I think we all think we're better than we actually are. And when I was young in my practice at University of Florida, myself and Tom Wright did a study where we would essentially register the scapula with the GPS unit, and then we would simulate placing a guide pin down our axis of the implant, similar to what Tom would do with his implant with the Biomet, where you put your central pin in, and then everything goes from there. And Tom and I both performed the same, despite him having lots more gray hair than me. We were both off in a third of the cases, a clinically significant amount. So even with really good training, we did do better than the fellows, thankfully, when we compared them, but we're not as good as we think we are. So while I've been navigating since 2017, I don't think that navigation is necessarily the only answer. I just think you need to do something to translate your plan from preoperative to intra-op, be it navigation, PSI, robots. Just trust the machines. They're going to get us where we need to go. And then, as Tom said, the next iteration of this is going to be taking all that information of where you leave the patient and then using machine learning and figuring out which patient gets which implant in which position to optimize outcomes.
Okay, well, I don't want to be one to court controversy, but what I would like to do now is, we've got three people doing three different things. I want you to tell me, Brad, why is navigation better than robotics and PSI, and why might it be worse? So, what are the pluses and minuses of the route you've picked?
So I have personal experience with navigation and PSI. I do not have any personal experience with robotics, although Tom, I've been trying to get him to take me to Canada to do the training for a good while now, and I can't get on the list. So if you can help me out, that'd be great. So why do I think navigation, which is my primary use, is the best? I do like the ability to change my plan intraoperatively if perhaps I'm having a very hard time getting it exposed with a very tight shoulder that I had already planned in 10 degrees of retroversion, and I just can't get there. And I decide now I want to take more bone. As long as I haven't done any reaming, I can back out of my plan, go to the screen, and I can change my version, change my implant position. If perhaps I planned an anatomic and now all of a sudden there's a big rotator cuff tear, you can flip and plan a reverse right there on the fly and continue on with your operation. So it's very flexible in that regard. The other thing is with PSI guides, there's always a little bit of a futz factor of, do I have it in exactly the correct spot? With less bone loss, I think it's a little bit more accurate. But as you get to pretty significant bone loss with those, when I've done kind of 3D printed implants, I'm very much hoping that I have my PSI guide in the right spot. And, sometimes you'll be putting in your screws, which are already pre-measured based on your plan that you get from the manufacturer. And all of a sudden you're 10 millimeters off. And then I'm worried that my implant is not where I actually planned it to be. Our data would show that navigation is within a degree or two of our plan, based on Ryan Simovich looking at some of his post-operative CTs. But that would be my case for navigation. I do think it's actually time neutral. By the time you get some experience, I use it on every case because, again, I am not as good as I think I am.
Okay, so it sounds like quick, flexible, accurate is your argument. Let's go to the robot. So tell us, Tom, make the case for the robot. Why should I use the robot instead of Navigator or instead of use PSI? What is the advantage that I get with the robot? And then what are the ugly parts? What are the parts of the robot that are not going to be as good maybe as the other solutions?
Yeah, no, obviously, Brad, if you want to get on the list, I'll make sure to call them and get you on the short list for getting training up and running with the robot platform. Obviously, we've been, kind of rolling this out slowly and being very intentional about it, for a lot of the reasons that, I'll probably talk about in the next few minutes. I mean, why the robot? I think it's pretty clear, as has been mentioned, having a machine can prepare the bone more accurately than we can. And that comes down to, the ability not only to place a pin, but to control how much reaming you're doing depth-wise. So, there's more three-dimensional information to all of this than just version inclination. We've boiled down a lot of our conversations on the glenoid to version inclination, and a lot of people don't talk at all about the humerus. So, the benefit of the robot is it allows us to really look at all of those aspects in three-dimensional space and understand, the implant relationships through our planning software. Now, I love Brad's point about navigation. I think that's also true for robotics, is that it is flexible in the operating room to change things based on what you're seeing, and that's one of the limitations of PSI is you could have a great plan for your bony alignment. And I agree, and I full-heartedly believe that the best way to get your soft tissues balanced is to get your bony alignment correct. But at the end of the day, shoulder arthroplasty, whether it's anatomic or reverse, is still a soft tissue balancing procedure. So you got to be able to adapt that plan in certain cases in the operating room to adjust to what you're seeing. PSI doesn't really give you the flexibility of that. And I think one of the limitations for maybe surgeons, especially who don't have as much experience, is they just get tied to the plan. It's like tunnel vision, and they're just like, well, I just got to do exactly what I did. And I think that that's not necessarily the right way to approach shoulder arthroplasty. As far as, limitations, obviously, the clear one is time. This is going to take more time than what it's going to take to not use a robot. You have to have, the robot set up, you got to position it, you got to bring it in, you got to do all the registration steps. Looking at my own data over the course of cases, my first 20 cases, it added close to 25 minutes, to my case, which is a lot. Between 50 plus cases, we got that down to about 5 to 7 minutes. So, the reality is, it is going to be more time investment, on the surgeon's part, to do this case, using robotics. You have to believe that, the accuracy that you're getting out of it is worthwhile for you and your patients. There's also a learning curve, and then, the financial implications. Robots aren't free. So, all this technology is expensive, and I know that, we haven't really touched on that with any of it. But PSI guides cost money, navigation systems cost money, robots cost money, and all of this in a value-based system, we have to be able to justify why we're spending the extra time, money, and effort, to do it. So, for me, I'm a true believer, obviously, that, getting the implants in the right position is ultimately going to be resulting in the best long-term outcomes for our patients. But similar to, knee arthroplasty and everything else that's using robotics, it's hard to prove that with, 2-year follow-up studies. So some of this data we won't know whether we're making a difference probably for 5 or 10 years in terms of the outcomes.
Yeah. Tom, you mentioned something that I think is very interesting, is like the cost of the robot. We also have to fight with our hip and knee surgeons for it. We have 2 ROSAs at our hospital, but if I wanted to use it, hip and knee books, a lot more cases per day necessarily to be able to use it. But my question is the cost part of that. How do you see that going? I know the navigation system used to have a capital cost up front, and eventually they transitioned to just having the units be free to use, and then you pay for the soft goods, which is like $200 a case for that. What do you see it happening for the robots, which is certainly a more higher dollar cost per unit than a navigation system, which is a screen and a CPU kind of inside of it? I'm really interested in what your thoughts are on the long term, what will happen with the robot and cost wise.
Yeah, no, I mean, great question. Most of the models now are similar to, what you're talking about, where it's a per case that they're charging you on. I refer to it as like the Gillette razor model. They're trying to give you the handle and hopes that you're going to buy all the razors. for years, but that only works if you have volume. So for someone who's doing a lot of shoulder arthroplasty, they can work that into the cost per case or whatever, to the point that usually there's not an upfront investment from the hospital for the robot, as long as you're achieving volume numbers. Now that doesn't work for somebody who's doing 5 or 10 cases a year, unless they have really busy hip and knee arthroplasty colleagues who are using the robot on off days that you're not using it. So it is a bit of a concern for people, and certainly it's not going to be the answer for everybody. And in certain areas with different models, the robot just from a space and or cost perspective, it may not be feasible for their system. So, I do think we need to have other options available, like navigation, like mixed reality, which I guess we don't have a mixed reality person on tonight, but that's another passion of mine. I think there's a role for that as well, in certain circumstances. So, using technology, as you said, I think is critical to helping our patients. Finding something that works for you and your system, I think is the key.
I just want to add to that comment about the cost. When PSI came out, I honestly felt that, this is not going to last, because navigation will come and it'll take it over, and so will robotics. But if you think about PSI in the most simplistic form, it's something that can be used anywhere in the world. So you could use it in parts of India, for example, if you have a 3D printer and you have approval to actually print it, or the South Pacific, where navigation and then robotics coming into these smaller countries or these big countries that don't have as much money is something we need to be mindful of as a global society. So that's something that's really interesting discussion. Australia, we're lucky, we don't have that problem. You can use PSI navigation. Robotics hasn't quite gotten here, but I had that experience at Columbia University where I saw robotics being done. Just a couple of comments about that. I agree with everything that you guys have said. When it's a routine case, not much deformity, reaming's not an issue, screw fixation's not an issue, I think PSI works fine. But if you have to have all those issues and you identify that, navigation, I think, adds another element. And I said I do both because I also want to guide my humeral side as well, which I do with PSI. I think robotics is a really interesting phenomenon, but there are lots of elements to, even with navigation at the moment. One of the things I'm concerned about is those pins in the coracoid and whether that'll cause fractures and those things that concern me. And with robotics, what I saw in Colombia, I saw a few times where that arm would come into the shoulder and it would just push everything in its way away. And that scared me. The chances of you getting traction injuries or it doesn't see where it's going, you have to guide it. And I think that those are all things that I'm sure Thomas and his team are ironing out, and it's a little way away. So I think there's a lot in development there, but the PSI guide for the routine cases is a pretty good way of executing your basic plan for a routine arthroplasty. And I think navigation is fantastic, and it's going in the right direction. One more thing about navigation is the registration process. That can be quite frustrating, and especially when you're learning how to go through the learning curve and they make you do it over and over because you didn't quite get it right. And that gives you a feeling of uncertainty sometimes too, that did I get it right? Because you're always worried about the navigation, and sometimes you lose focus on what's in front of you, and the patient in front of you and the anatomy, and I think it can be a bit distracting when you're starting out. And the most important thing is the soft tissue balance. I take your point, Thomas, about getting the cuts right and getting the balance right. But really, the shoulder is a far different an animal to the hip and knee, where the soft tissue balance is so crucial, as we know, and even when we're doing reverses for intact rotator cuff. And I think that's an area where the basic sciences needs to really take us next level and incorporate that into the planning and execution, because right now we have no idea about soft tissue balance when we execute. Doesn't matter which way we do it. So that's an important area that we all need to do some more research on.
Sumit, I wanted to ask you, one of the purported benefits here of both of the other options here, navigation robotics, is you can change your plan. And so there's some shots fired at PSI that it's a non-changeable plan. So I guess I wanted to ask you, you're using a lot of PSI. How often is it that you put in your PSI guides and you say, this is not going to work, and you abandon that plan and you find, oh man, I wish I could have changed this a little bit? Is that a real problem for you or no?
Okay, so that's a very good question. So maybe like over a year, Peter, I'll have one or two cases where I just can't get that PSI guide to fit despite doing a beautiful exposure. And that's one good thing PSI does. It makes you get a really good exposure. There was one particular case where I just didn't notice in the subcoracoid space, there was a large chunk of bone. And I just couldn't get my guide to fit because the guide was supposed to fit in that subcoracoid space, for example. I felt stupid at the end of the case thinking, oh, wow, I just couldn't get that thing to fix. And so in those situations, you have to be adaptable. But in saying that, the preoperative planning does help you because you still understand what you're trying to achieve, but you don't have that guide like you usually do reliably to execute that. And I remember when I was training with George Athwell, at that point in time, we were doing all the planning, but we didn't use anything to execute the plans. But the planning in itself does help you quite a bit because you know what you're targeting, and then you have to rely on your skills to do that. And we're all trained to do that, but it certainly does help to have the PSI guides. But then I also identify cases where there's a lot of deformity. I'm worried about where my screw purchase is, the length, where I will have navigation in play as well. So I can use both, and I've done both. And I think one other question that I was asked through the chat group was, what about accuracy? In fact, I did a little experiment where I took a PSI guide because I have both in play in those difficult cases. And I sort of line up where my wire is going to go. And then I also bring in the navigation and I check it. And it's actually quite remarkably accurate, and that really gave me faith as that, look, if you get the PSI guided to fit nicely in the navigation, they're almost identical. So that was a cool little experiment that gave me a lot of faith in both systems I use.
That's great. I've always wondered that about, how accurate is PSI versus navigation. I continue to wonder, where robotics will fall into that too. I mean, that's really interesting. You had a system where you could kind of look at both. I would say that, like, as far as navigation goes, the registrations, the learning curve is somewhere between 5 and 8 cases for the system that we use. After that, you kind of get closer to time neutral. And, especially in a reverse, I tend to, and our studies would show, the ones we did with UF, you put in fewer screws when you navigate as well, because you can put in longer screws. You're in better bone that has better purchase. So you end up spending less time putting in screws. I put 2 into my base plates as long as they're both rocks. Before I had navigation, I would put 3 just for security. So I do think you can make up time on the backside after the registration, which again takes less than 2 minutes once you're up and running past that 5 to 8 case learning curve.
Those are great learning points. And Sumit, I think as we can move towards wrapping up, we're left wondering what the future is. And I think you've alluded to a very key concept that we probably all need to pay closer attention to and innovate. And that's that concept of soft tissue tensioning and pressure on the implant. I think that has meaningful contributions to polyethylene wear, as you thinking about traditional bearing surfaces, but then also looking at the individual subunits, tension on the coracoid, that leading to maybe this iatrogenic impingement picture, as well as deltoid overtensioning. So I'm interested in that as a future potential benefit to our patients. I'm curious, Tom. You're at the robot stage. So what's the future look like for you? What's the next innovation that you think is going to deliver better care for our patients?
Yeah, great question. I think it gets down to using the data that we can achieve through robotics and other things, as was mentioned earlier, with machine learning and AI, to really develop some good predictive modeling of what we should do for patients. And I know the Exact group and other people have tried to do this. The challenge is sometimes with AI and machine learning is the output is dependent on the input, and at least as far as implant position, and what you're talking about too, with like muscle quality, bone quality, all these things will play a role, and we don't have any ability to accurately input that always into our models. So the more data that we can obtain accurately, that is good quality data to inform these models, I think is going to be the game changer. That's going to be the thing that really moves it forward. The other aspect of robotics that, we're certainly not there yet, but this is, when I started the robotics project, I told them there's really three, goals that, robots have to do for this to be a true added value, to surgeons and to patients. The first is it has to be accurate. And I think we've come that far. Like, we have accuracy. The second is it has to be easier for people, especially people who don't do a lot of shoulder arthroplasty. I don't think we're there yet with the robot. To Rana's point, the robot right now, it requires an excellent exposure. There's a lot of moving parts. It's probably actually a little bit more challenging to do a robotic total shoulder. In the current state, we're certainly working towards making all that more user friendly. So I don't think we've achieved that ease of use yet. And the third thing is that, it should be able to make shoulder arthroplasty a minimally invasive procedure, mainly a subscap sparing operation where we don't have to see things as clearly as we would otherwise, and we can trust that the robot's going to be able to do a good job. Now, again, that's aspirational. So we're really not there yet. So we have a long way to go yet, but I do think the future is friendly. I think we'll get there. We'll be able to do these minimally invasive procedures, which will change rehab for our patients after shoulder arthroplasty drastically and allow them to get back to their activities sooner than they would otherwise.
Brad, future state, what's your ideal solution?
So the machines are going to win. Machines being the
Cybernet
computers.
rules.
So, a lot of what Tom said, I completely agree with. We will get to a point where you can work through the rotator interval and be able to leave the rotator cuff intact and perform a shoulder arthroplasty. There are conceptual ways that you can do that. The technology and dollars have to catch up to that. I think the next big leap that we're going to see as shoulder surgeons is absolutely on the AI front. Kind of sneak peek into some of the stuff that's going to be coming out that we're submitting based on that as imaging based things where you can take CTs of people preoperatively and predict their postoperative range of motion based on just their preoperative CT. There are certain deltoid shapes that are predictive of good outcomes. We're working on the rotator cuff musculature portion of that right now. We're seeing some scapular morphologies that are associated with outcomes. All of these things are going to help pick the right patient for the right operation. And more importantly, perhaps steer somebody away from an operation that's going to be at risk for failure or a poorer outcome. So there's a lot of information with a CT scan that we don't see as surgeons that is available for us to analyze. And these things are going to become available to surgeons everywhere. They can get a CT scan to better counsel our patients and kind of guide them to the correct operation.
Sumit, in the spirit of international diplomacy, you get the final word on this.
It's very kind. Look, I agree with everything that's been said. I think that the future is very bright. It's inspiring in a lot of ways, but I think we must be cautious in the way we take those steps because with big data and AI, if you put nonsense in, you'll get nonsense out. So you have to be careful. I think that there is a lot more we can do in the basic sciences realm. For example, in our lab, we have a shoulder simulator that has acromial strain gauges. You can do digital volume correlation, really understand what the effect on implant positioning and movements are in terms of forces. I think the soft tissue balance is absolutely integral to take us to the next level in terms of patient outcomes and improve their outcomes and minimize complications. I also feel that maybe CT is not going to be the future. Maybe in 10 years' time, we may be using MRI for planning with a vibe sequence that gives us as good imaging as a CT scan. So we can actually do an operation that's not only planning and focusing on the bones, but also looking at the soft tissues. Because if you are able to get data on the soft tissue balance better, then what better than MRI to actually give you an understanding of how the shoulder will be balanced, because it gives you the bone data as well. Maybe it just requires a tweak in sequence. So those are the things that I would add to all the absolutely wonderful things and appropriate things that my colleagues have said. So I think the future is bright, but we still need to be mindful of the basic sciences and getting things right at the benchtop level before we're going into the patients, and being also a little bit careful with the big data and how it's analyzed and what comes out.
Well, I wanted to thank the three of you for coming on. This has been amazing. It's great to hear your different approaches, your reasoning. I mean, everything I said, it's so well thought out. I think that really plays into the work you guys have done to really get this right. So thank you for coming on and spending the time with us. I really appreciate it.
Great. Thank you again, gentlemen, and we appreciate you being involved tonight. For all our shoulder and elbow listeners out there, please don't forget to subscribe. And for Peter Chalmers, I'm Brian Waterman. We'll see you next time. Thank you.